person doesn't have any symptoms and has had an incidental finding of coronary disease on their heart test.
Sometimes they block off completely one morning or afternoon. That's a heart attack. You can see that if you had the CT scan, then you were more likely to be taking a statin medication, which reduces your risk of heart attack every year. You're more likely to have your blood pressure treated properly. You're also more likely to be taking aspirin. That better medical therapy, the better tablet therapy, prevented heart attacks for these people who'd had CT scans.
A patient can't make this decision looking through their own report.
No.
And so this is why it's important that an individual's result is discussed with a specialist to interpret all of this, because like we said, sometimes no stent is the right option, sometimes a stent is the right option, sometimes surgery is the right option. And so getting a true expert in the room who understands this and understands those nuances and the data is...
If you're 75 and you don't have coronary disease, there's something really weird going on.
Saying that some coronary disease could be normal for people as they get older. Welcome to Delhi Belly, a series of conversations tailored around preventative health for people of Indian origin. My name is Nikhil Alawalia, and I'm a cardiologist and health researcher in cardiovascular disease.
I'm Abhishek Joshi. I'm a consultant cardiologist in London. It's lovely to see you again, Nikhil.
Yeah, lovely to see you too. And today we're going to be talking about another scenario, something I get text messages about, and that is, again, heart disease and heart risk. So I'm going to, again, paint you another scenario. You have a 75-year-old auntie or a masi who sends you a message that they've just had a health check done in India. They've had a CT angiogram or a CT calcium score, CT coronary angiogram, a CT scan looking at their heart. And their doctor told them that they've got coronary artery disease. They're very anxious about this and don't know what to do. They've been generally very fit all their life. They're quite active. They go for walks. They think they're pretty well. But now they've really taken to bed a lot more. They're not going on their daily walks because they're scared of heart attacks. They're quite anxious, not sleeping properly. Every twinge they feel, they think could be a heart attack. And other people in their family are telling them, go get a stent done because it helped their friend. So really, I wonder what advice you would give to someone in that position who's had coronary artery disease picked up on a CT scan, and perhaps we can talk a little bit more about the evidence around that.
Okay, well, firstly, I'm really sorry this has happened. Like, no one wants to find that they've got heart disease on a CT scan, particularly if they weren't expecting it. And it can really worry people because, of course, the heart is what keeps us alive, right? We're cardiologists because we think it's the most important organ. No one wants heart disease. The reality is almost everyone's going to have some heart disease on a CT scan. And I think if I were talking to my auntie just before the CT scan, at the age of 75, you said? Just before she went into the scanner, I would say something like, you're probably going to have something on this scan. And the reason for that is that, as we've been talking about, the thickenings that we measure on CT scans that make up what we call coronary artery disease or ischemic heart disease, they build up over the course of your lives. They start in your 30s and then they develop over the course of your life. By the time you're 75, I'd be amazed, or very few people don't have something on that scan.
Hold on, so you're saying that some coronary disease could be normal for people as they get older?
I think some coronary disease, yes. If I say, I'd be stronger about that. If you're 75 and you don't have coronary disease, there's something really weird going on, right? Almost everybody who's going into a CT scanner at the age of 75 is going to have some thickening, not blockages, but some thickening of the arteries around the heart that give the heart its blood. And that's what we call coronary artery disease. So I wouldn't be particularly worried if I had some of that when I was 75. Of course, there are loads of different types and grades and severity, which I think we're probably going to talk about. But just having it on its own, just saying, there's some thickening of the arteries, that's important to take seriously. But it's an extremely common finding on someone who's 75 years old.
Fine. And just to dig in to what coronary artery disease is again, people would have seen that model of the heart, and the heart has its own blood supply, which are like pipes, like water pipes in a house. And you're saying over time, it is normal to accumulate some furring up or some thickening of those pipes. But I guess the problem is if those pipes get really narrow or really thickened that blood can't get to the heart, or if it happens all of a sudden, and that's when people run into problems like heart attacks.
Right. So those thickenings are made of something called atherosclerosis. I think we talked about that in the last episode, right? And that is a kind of build-up of some of the cholesterol in your blood, plus some of the blood cells, and they cause thickening of the arteries that can slowly cause the tube that the blood goes down to become more narrow. Up to about, we say sometimes 70% narrow. It probably wouldn't even be noticed by the person. It wouldn't cause symptoms. It wouldn't cause them any pain. Sometimes they block off completely one morning or afternoon. That's a heart attack.
Okay.
And we were talking about stents earlier on. a stent in the context of a heart attack is an excellent idea. It saves your life. It makes you live longer. It can prevent future heart attacks if you've had one already. But if the narrowing is happening slowly and you see it on a CT scan and it hasn't caused you any pain, then that's one type of narrowing that we might talk about. And if it is causing you some discomfort, and by discomfort, I mean you might feel a pressure sensation in your chest when you're walking or climbing the stairs or doing something like that, that's called angina, as you know, then we might treat things a little bit differently there too. So what we haven't really got from the scenario, because it's hypothetical, right, is all the other stuff about the patient that normally we'd like to know in the context of a health check. At the moment, we just got the heart scan.
Fine.
And the
so you're saying that in the setting of a heart attack or in the setting of tightness in the chest, a stent, which is some scaffolding that goes into that pipe around the heart to open it up, is a good thing. We've seen that there's benefit, that people can have less heart attacks, people can feel better.
But in this situation, a stent, I don't think, has got a huge amount of evidence to support making people live longer, right? And you know that from the Courage trial, for example. We should maybe talk about
that. Got it, yeah. Let's talk into some of that data. So let's move into the scenario where the person doesn't have any symptoms and has had an incidental finding of coronary disease on their heart test. And, and we do have a lot of data. And because this is so common, like you said, some coronary disease is common that we have in the UK, in the USA, and in some studies around the world have got that data about what to do in this setting.
Yep.
And one of those studies was the Courage trial, which looked at 2,000 people in North America. And that showed that, again, in the setting where there isn't a heart attack going on, those patients don't live longer and don't have less heart attacks.
Yeah. And that was a surprise. That was a surprise for us. You've got to remember, like that, we expected to see stents prolonging people's lives. And when the results came out and it didn't, that was a real surprise. And we had to adjust in cardiology.
Yeah, that was before my time, I'll say.
Well, okay, fine. But we thought we were, I wasn't doing it, but people thought putting stents in was prolonging people's lives. The Courage trial came out, really challenged that idea.
Fine.
And now in the UK, at least, it's just got a fundamental part of our clinical practice.
And I guess that's what set the scene for the multi-million-dollar ischemia trial, which was run out of America, but actually had a lot of patients recruited from India. So there were 5,000, more than 5,000 patients in the study overall, and about 10% of those patients were recruited in India.
Wow, I did not know that.
Yeah.
Obviously, I knew all about the study. So when we're talking about studies here, just to be clear for our audience, what we do is we take a big population of people and we decide that some of those people would get a treatment or an investigation or some form of medical stuff, and the other group would not. And then we compare those two groups statistically to see if they do better, right? So the Courage one you were talking about, those were people having stents placed in narrowed coronary arteries, narrowed arteries around the heart. And the measurement was, are they going to live longer? And the answer was they live the same amount.
Okay.
Then the next measurement was, are they going to have as many heart attacks? And the answer was they have the same number of heart attacks. There are some cases where stents are helpful. We'll talk about those a bit later on. But for ischemia, there was some quite complicated measurements that the patients had to have. There was more than just the CT scan. There were some other measurements they had. Some people with really significant or severe disease on the CT scan didn't get into the study. So if you've got that sort of disease, then we can't talk about you in this context. But what they found was that having an angiogram or having a stent, again, didn't improve people's life expectancy or reduce the number of heart attacks. But what I didn't know was how many Indians there were in. Tell me again, there was, 5% of the people in
10% of patients were recruited from India, from about 23 different hospitals in India.
Great.
So we can really extrapolate to some extent this data and that finding that if just because you have some coronary disease doesn't automatically mean a stent will help you live longer.
Yeah, sure.
So this was a real big study that for many people was quite conclusive about that there are a group of patients who won't benefit from a stent in terms of living longer. But again, it's important there were caveats to getting into that study because patients with really serious coronary disease, and by that I mean coronary disease in certain parts of their arteries, were not included because we think those patients are at much higher risk. And so even if you didn't have many symptoms, or if you didn't have any symptoms, but you had disease in the left main stem, which is a part of the coronary artery system, or the proximal LAD, which again are technical terms, but really mean in quite high up in the coronary system, those patients may well benefit from having a stent or surgery. Or
something else, maybe a bypass operation.
Regardless.
So there are patterns of narrowings or thickenings in the arteries that we know, and we don't need to do these sorts of tests now because we learned a long time ago. Those patterns of narrowings, they do mean that your life's going to be a little bit shorter unless someone does something about it.
Okay.
And the important thing is that we can do something about it in those situations. Whether stents are the thing that you would do about it in those situations are questionable, but there are certainly some patterns of disease, some combinations of narrowings where a bypass operation, for example, would be the recommended thing to do. And so if I had an auntie who had that combination of disease on the CT scan and they were being offered an operation for their heart, I would suggest to them, if that were the case, that they strongly do consider it.
Okay.
Because it's not always the case that just leaving things alone is the right thing to do. And you don't want to just leave things alone if things are really serious.
Yeah.
But of course, we don't know exactly what the CT scan results are, right? So let's imagine, instead of it being that really serious combination, that instead what we're seeing are some thickenings around the arteries that are not causing blockages. And she didn't have any chest pain before. So then we need to focus on something else, right?
Yeah. I mean, I think this podcast is not medical advice, and no one individual can extrapolate what we're saying and decisions to their own care. And I think what I'm hearing is a lot of the decision making is pretty advanced and complex.
Yeah.
And so a patient can't make this decision looking through their own report.
No.
And so this is why it's important that an individual's result is discussed with a specialist to interpret all of this, because like we've said, sometimes no stent is the right option. Sometimes a stent is the right option. Sometimes surgery is the right option. And so getting a true expert in the room who understands this and understands those nuances and the data is fundamental.
Completely correct. And I suppose at the beginning what you said was that this Mossy had a health check, right? Now, a lot of the information we have about the diseases that we're seeing, the narrowings in the arteries and stuff, they're not from people who've had health checks. They're from people who've come along with discomfort in the chest. So we know if you've had some discomfort in the chest that might be angina, might be coming from the heart. We actually know quite a lot that CT scans in those sorts of situations do improve people's healthcare, but it's not because we put in stents or because we can see something that we could do mechanically to push the narrowings out of the way, right?
I think you're talking about the Scott Hart study.
Well,
is that right?
I'm always talking about the Scott Hart study, Nikhil, because it's such an important study done by such amazing scientists from Edinburgh.
So the Scott Hart study looked at people who were having some discomfort in their chest, gave them a CT scan, and then followed them up to see how they did. And the magic result of this was those patients did do better and did have less heart attacks in the future. Now,
how many Indians?
Yeah, well, that wasn't published.
We don't know, right?
That wasn't there,
fine.
but again, I think those patients were all recruited from Scotland, so perhaps representative of the UK. But the important thing to understand is those patients did better. Those patients had less heart attacks, not because they got stents, but because their doctors took their coronary disease more seriously, started aggressively addressing their risk factors like blood pressure, cholesterol, diabetes, and helped them live longer through tablets.
Yeah. So it's an amazing study. And again, it was a bit of a surprise when it came out, which is why I love talking about it. People who had CT scans just seem to have fewer heart attacks just from having a CT scan. And obviously that can't be the case. How does a CT scan stop you having a heart attack? Well, when you dig into the data, and actually the authors of the Scott Hart study have shown this themselves in subsequent follow-ups, 10 years later, you can see that if you had the CT scan, then you were more likely to be taking a statin medication, which reduces your risk of heart attack every year. You're more likely to have your blood pressure treated properly, which again, as we've talked about, reduces your risk of heart attack every year. You're also more likely to be taking aspirin, where there's a lot of debate about whether people should take aspirin to prevent a heart attack if they haven't already had one. So maybe we could talk about that in another half-hour-long episode in the future. But overall, that better medical therapy, the better tablet therapy, prevented heart attacks for these people who'd had CT scans over the course of their lives. A fascinating study. And it applies to this Mossy, right? I don't think there's any question if she's had a CT scan that shows some thickening of the arteries, regardless of what it is, we ought to be managing those risk factors and preventing that thickening from worsening over time.
So that's the first conversation before the stent conversation.
Absolutely.
So first conversation, get on the right tablets. And then I think for the next conversation about does this person need a stent based on their anatomy, based on their other risk factors, based on their symptoms, that's a difficult decision. And I think to try and give the people listening some tangible sort of next steps to take if they're ever in that situation. I think it's important to engage a specialist who knows what they're talking about. And often, if you're not having a heart attack, you do have a little bit of time to try and identify the best person to make that decision. So if you're being pushed into having a stent, if you're being rushed and you're not having any pain, a bit comfortable, sometimes it's important to make sure the right people are on board and making that decision.
Yeah, there was a really scary article in Time magazine years and years ago. I remember it. It was the front page of Time. I don't know. Do you ever read Time?
Sometimes.
Maybe you're probably too young. About a guy who had a CT scan. And on the CT scan, it had found some narrowings. And like the next day, he had his bypass operation. And he didn't know he had any illnesses the day before, right? And those sorts of stories, they're quite scary. And they probably don't fully follow the medical evidence. If you're not experiencing chest pain, then the results of your CT scan mean, regardless of what they are, you still have a little bit of time to engage with a good cardiologist, make sure you're getting a good opinion, but you must get an opinion, and then set off on the right treatment pathways for you. It is individualized. Sometimes, you said it's a difficult decision. Sometimes it's a really easy decision. This person really does need a stent. And frequently it's a simple and safe procedure to have that does make people feel better. But it's not always the decision that just having some thickenings of the arteries means that someone should have a stent.
Yeah, and I guess it's easy in some ways for us to be sat here as armchair doctors giving advice of what to do and what not to do. Yeah. But you've got to acknowledge there is an emotional burden to living with coronary disease, even if it is deemed not to need a stent. And so there certainly is sort of needs to be taken into consideration the anxiety that might cause, the fear that might be caused, and address that. So I think, again, all the more reason to be on good medications and be engaged with your health and seeing the doctors to sort of get on the right treatments. But certainly take that into consideration when a doctor says you don't need a stent. That's not necessarily the end of the picture.
Yep, absolutely.
There's a lot of other factors that need to be addressed.
Yeah, totally. Nothing more reassuring than the sense that you're doing the most that you can for your health. Mm-hmm. Sometimes the most that you can do for your health is just taking the correct medications and preventative therapies and doing your exercise and things like that. Sometimes the most you can do for your health is a big invasive procedure like a bypass operation, and a good cardiologist and a good team will move you through that decision-making in a really safe way. I think that is so important to Indians because it's so common that we see heart disease. And it's really important because it happens so much earlier in life, or sometimes it happens in the context of a family that often doesn't come across when we're seeing people one-to-one in medical care, that you get the best advice you can get, that you make sure that you've taken your time to think about doing the right thing, and that your doctor can kind of justify the decisions that they're taking for you with maybe reference to the sorts of information that we're discussing now. Yeah. It's available for all cardiologists to see what the benefits and risks and they can individualize that to the individual person or patient's care.
Fine. So I guess as the patient then, you should know that this is not black and white. And I think being comfortable enough to ask for that explanation and try and understand why you are or are not having a stent fitted if you've got coronary artery disease is your right. And you should feel empowered to ask those questions.
Absolutely.
And not take anything for granted.
Brilliant.
Great. I think we'll leave it there for today and look forward to discussing something else next time.
Thanks. Great case. Thanks for bringing it.
Yeah, no worries.
See you.
Bye.